Afternoon, everybody. So the story of Ardens is a story that is started by GPs. So I'm a GP by training, and a number of GP colleagues and I started Ardens because, as per the Primis team's presentation, although primary care is ahead of a lot of places in data, there's still frustrations with the quality of the data, what you can do with it, and also the limitations of the systems that we find ourselves working in. So we started building tools that we wanted to improve our own practice, and that was 12 years ago, and it kind of grew from there into really quite a wide tool set, and we now cover most of England. We cover 87% or thereabouts of English GPs. There are various reasons why we haven't gone into Scotland and Northern Ireland and places yet. We've got two main elements. Ardens Clinical is built within the clinical systems, so the two major clinical systems, EMIS and System 1, and that is data entry. That's curation of data on the way in to try and drive up data quality, and that consists of a number of elements which I won't go into detail, but you'll see them in a moment. And then Ardens Manager is our software platform. This is a data analytics tool, web-based, system agnostic, that can interpret and dashboard data for analysis, and also now is giving us the ability to launch patient records directly from it, so one can go back into the clinical system to look at the detail when patients come up in a report. What do we do? We try and improve data quality input, as I've said. We try and help call to action these actionable insights that everyone has been talking about. Again, that's our bread and butter. And we're trying to save time for clinicians, busy clinicians. We're trying to improve safety, and we're trying to improve efficiency and keep people focused on the evidence base, because the evidence base grows. It's very, very difficult to keep on top of it. So I'm going to rattle through a number of slides. It's going to be very rapid fire, but if anybody does have questions, please do tell us at the end. And myself and Rob, who's our CEO sitting there, one of us will be more than happy to go through in a sort of bit more detail with you later on. So one of the things we do is respond to CAS alerts. So practices often want to respond quickly and efficiently to a CAS alert from MHRA, or sometimes people like the NPSA. So we pick up on those. We're on the National Cascade Systems, and we build alerts, in this case reports within the clinical system, to draw people's attention to those and help them action them quickly. And you can see there a list of some of the ones we have. Secondly, a real-time alert. So sometimes a patient will have a specific characteristic, and as I think Kerry said earlier, you don't want an alert popping up every time you see a patient. It's really, really annoying. And so we try and curate these alerts. So if you look at this one on the front here, you're prescribing a quinolone to someone who appears to have a higher risk. That will only pop up if the patient fulfills those characteristics. Again, it's dependent on the coded record, but it still helps draw your attention in those cases where it's relevant without overfiring and annoying you and giving you alert fatigue. Ardens Manager, so this is a screenshot view. I'm afraid it's probably a bit small for you to see, but this is a screenshot of our dashboarding system. So again, we have the safety alerts produced there so that you can, at a glance, see how you're doing and whether there's any specific areas that need action as part of your governance procedures. Medicines Optimisation. So this is really to do with what someone else was talking about in terms of getting people on the right dose. And again, it's fraught with difficulties in the terms of how things are recorded. Are you prescribing 2.5 milligram tablets of something, or 1 5 milligram tablet? We don't know exactly what the patient is taking. But again, with those caveats, these are aiming to sort of subdivide patients and give you your target groups into actionable groups. So we subtract people like that top one. It says no MTT recorded, so that's maximum tolerated. So we want to make sure that people are excluded if someone's already done that clinical review where possible. Recall management. So again, proactively making sure that all those people with chronic conditions on relevant medicines, people that have a genetic condition that means they need a colonoscopy every 5 years or whatever it may be, trying to make sure those people are stratified into ways that you can automatically have practice systems that will organise the call and recall, but we provide you with the cohorts to try and make that job a bit easier. So in this case, DMARDs. So template guidance. So this is one of the, the key tenets of what we do, which is trying to improve the data on the way in, so that whatever system you're using, whether you're using Ardens Manager or Open Prescribing or one of the other tools, you can see consistent data to try and make sure that people are recording it in a consistent way on the way in. We can't force people to do it, but by providing templates, we curate the list of available SNOMED codes for various things so that people are entering data within the parameters that are then returned in our reports. So again, these are just some examples of how the templates look on the left in System 1, on the right in EMIS Web, and there's slightly differences in the way the systems operate, but they are according to the same principles. We also have alerts that will tell you in a sort of low-key way, rather than popping up like the quinolone one we saw earlier. These alerts are more low-key. These are, if you've got a few minutes at the end of the consultation, you want to make sure you're using that time effectively. What does this patient need? So on the left is an EMIS Web tool, which is all the blood tests required. So the top panel is medication monitoring, and then below that you've got ones required for long-term conditions. If you double-click on that, it'll open up a panel giving you more detail about why they need those things according to us. All of our advice is based on national guidance, so generally NICE where possible, but also other sort of central, reputable sources of guidance and so on that GPs would be commonly expected to follow. And on the right is an equivalent in System 1 of a drug monitoring alert telling you they're on a shared care register, they're on methotrexate, but they haven't had their required monitoring. If you want to see how you're doing, how are we doing? We know we were down on our mercaptopurine monitoring last month. How are we doing this month? Again, you can use Ardens Manager to look at that, and you can also compare. See a little switch in the top left there says benchmark, Evergreen Medical Centre. That allows you to compare yourself against practices in your PCN or your area, depending on data sharing agreements. That patch can be as wide or as narrow as you wish. Formularies. So formularies, long time been a feature of Ardens System 1, we're now building them into EMIS as well. They work on a slightly different principle. In System 1, you have ability to prescribe from a template. So on the left there, you can see an inhaler template showing you which ones to prescribe, and there's some grayed out options which are less suitable for the patient according to the options you've chosen. On the right, we've got the EMIS prescribing protocols, which are the same principle, but use different functionality within EMIS to again, lead you to the required prescription for that patient. A bit more on formularies, showing you also how you can translate the prescriptions into a ready populated medication administration chart for community use. Some more formularies here for long-term condition, for menopause HRT. We do formularies for all the different sort of areas you can imagine, really, along with our template offerings. And then again, we were talking a lot about cost earlier, so cost efficiencies. Again, we will offer those as part of our formularies, and sometimes these are curated according to the wishes of local areas. So sometimes we have particular drives for something in an area, and we will customize our tools for those areas. Antimicrobial resistance, I'm going to skip over this quickly, but we talked about that earlier. You can see here we've got fever pain scores allowing you to record the data in a consistent way, and then guiding you onto allowing you to print target leaflets for the patient, etc. And this will tell you your first line choices, again using the formulary to guide you through. On EMIS it's like a flow chart that guides you through multiple choice menus. System 1 it's laid out as a template form. Environmental impact become a big hot topic in the last few years. So again, we've been asked for searches and reports for that. This will guide you as you're prescribing so that you can choose, and also you can record that you've considered that. So where you've chosen a non-compliant option, you can justify why you've done that, and it's recorded in a consistent way. Finally, CQC. So we worked with the CQC to develop a range of searches that will allow their inspectors to do a pre-inspection trawl, which helps them know where to focus their efforts. And the key factor about this is that the rule sets for this are open access. So like prescribing open safely, we've published these on an open access area of Ardens Manager so that any other system supplier can build according to exactly the same transparent logic in order that they're consistent across all systems, both the ones we provide for and any in the future. That's all I'm going to say. As I said, please do come and catch either Rob or I later on for more detail on any of that if you'd like to.